Hello and welcome again to another session of 8 questions in 8 minutes. Today we're going to focus on pregnancy. For that, we have with us Jean Cox. Jean, thank you very much for being with us today and answering our 8 questions in 8 minutes. Welcome to our show.
Thanks for inviting me.
We're going to start with our first question. Now, the Academy of Nutrition and Dietetics recommend key concepts of a healthy lifestyle during pregnancy, and that include appropriate weight gain, balanced diet, regular exercise, and appropriate and timely vitamin and mineral supplementation. How practical are those recommendations when individualizing patient management, and what is your experience clinically?
So healthy diet and weight and exercise are certainly important concepts, and we talk about them a lot in prenatal care.
Yeah.
However, it's also important for the general population.
Yeah.
And for healthy pregnancies, we want to focus also on the community. So preconceptual nutrition is as important or more important for healthy pregnancy outcome.
Yeah.
As far as supplements, we need to talk about that preconceptually. So it's a public health approach. Half of the pregnancies in this country are unplanned. And so we want anybody of childbearing age who has the slightest possibility of getting pregnant should be supplementing with 400 to 800 micrograms of folic acid a day. Because if we wait to talk about it until they get into pregnancy care, by then it's too late to talk about what folic acid might have been able to help with. So yes, it's important clinically, but it's much more important from a public health perspective.
We're going to move into our second question. The NHS in the UK says, and I quote, "There's no need to eat for two, even," close the quote, "even if you are expecting twins or triplets, knowing that pregnant women have a stronger feel of hunger. To eat healthy often means varying the amounts of different foods, and how can dietitians manage that with patients consistently?"
So they're right. They don't need to eat double the amount of food because you have to think about how big one of those kids is.
Okay.
But they do need to eat more carefully. So the increase in calories does go up. There is an increase in calories, but the increase in the nutrient requirements are much higher in many cases than the increased amount in calories. So they do need to eat a little bit more, but they need to eat more carefully. Your question about them being more hungry, that may or may not be the case. In the second trimester, that might be the case.
Yeah.
But in the first trimester, they might have nausea and vomiting, and it makes it hard to eat.
Yeah.
In the third trimester, they're going to be running out of space, and it's going to be hard to eat. And so we have to talk about smaller, more frequent meals.
Yeah.
If you've got somebody who's pregnant with twins and triplets, that problem is worse. So they have even higher needs, and they have even less space to get it in. And so that's what we focus our attention on, is helping women accomplish that, getting in the nutrient needs in the small space and time that they have to do it.
Lovely. Let's move into third question. There is a risk in eating bananas during pregnancy. This is a myth or truth, or is this a myth or a true fact? And what is your experience clinically, knowing that bananas are right in potassium, magnesium, manganese, vitamin B6, they have dietary fibers, copper, and folate? Is it like a magic fruit, or is that a myth? What's your intake on that?
Well, you're asking a complicated question. So in general, bananas during pregnancy are fine. Yeah. But the more complicated question in there is when you get a question that you're not expecting, then you need to find out what that person is really concerned about. So ask them more questions about what their fears are or what they've heard. So, for example, if she's asking you, can she eat bananas because you've just told her that she has gestational diabetes, then yes, she can eat bananas, but it's going to be a smaller amount and you're going to combine it with protein.
Okay.
If her concern is she's heard that bananas cause allergies, you can be allergic to bananas, but that's not related to pregnancy. She would have known that preconceptually, and if she was able to eat bananas preconceptually, there's no reason to believe that she's going to have trouble now.
Okay.
If she's heard that bananas cause constipation, Okay, increase the fiber, increase the water, increase the walking,
Okay.
and just deal with that. If she's afraid of bananas for some other reason, whether or not you believe there's a basis for that, if she's afraid of it, then avoid bananas and just give other fruits and vegetables that give all of those critical nutrients.
I see. I see. Great, great. Let's move into our fourth question. Preeclampsia, hemorrhage, and death of mothers can result from poor diet, lacking key nutrients during pregnancy, not to mention stillbirth, low birth weight, wasting, and development delays for children. What advice would you give the dietitians to avoid such complications from your long experience?
Yes, so you'd certainly want to help prevent it if you could, because it's bad for both mom and baby. If you have access to somebody preconceptually, get her in normal weight range as well as you can. Have her be in optimal nutritional status preconceptually as much as you can, because that will help the formation of the placenta and the communication of the placenta to the circulatory system, and that may help lower the risk. Once she's pregnant, if that's when you have access to her, make sure that she's getting enough calcium from milk products, not calcium supplements, milk or milk products. And make sure that she's getting enough fruits and vegetables to get optimal levels of antioxidants and the anti-inflammatory components. Keep her weight gain in normal range. Keep normal exercise. You don't have to severely limit the salt consumption, but if she's eating a lot of the very high salt foods, a lot of processed foods, a lot of fast food, that kind of thing, take those away. If she has diabetes, control it as well as you can.
Lovely, lovely. We're going to move into our fifth question. What's your take on preconceptual nutrition and how much stress do you put on with your clients? The ACOG guides to planning for pregnancy set some nutritional related topics to address at preconceptual visits. Can you guide the dietitians on the main ones to address clinically?
So preconceptual visit from a nutritional point of view is a wonderful idea. But if we do, I had one just the other day. If we do, what we're trying to do is normalize weight to get it as close to normal range as we can. We want healthy exercise. We want to start her on prenatal vitamins. We want to make sure there are no mega doses of any vitamins, no herbal supplements, none of those other things. There isn't a generally accepted fertility diet. So what we're looking for is a general, well-balanced diet, the same type of diet that we would prescribe if she was already pregnant. And we just want to resolve any ongoing problems that are happening. So for example, if I have somebody who was just pregnant, we want to postpone the next pregnancy because with a very short interconceptual period, we need time. We need enough time to have her replace the nutrients that were used in the last pregnancy, or she's going to have much more trouble this pregnancy. So we would do that counseling, try to get her high nutrient intake, and try to extend the time before she conceives again.
Lovely, lovely. Let's move into our sixth question. Pregnant women are concerned about their weight gain, and this might lead to some eating disorders, leading to obviously malnutrition with risk of imbalances, deficiencies, weight gain abnormalities, if not controlled. Now, what is your experience with this clinically, and what best practice advice would you give on this?
So if you have somebody with eating disorders, treat them very carefully. You can certainly manage it, but you can't solve the problem. And you will often hear it come back right after delivery. She'll say things like, baby is too big, or she'll know her postpartum weight much sooner than you would have expected her to even care about that.
Okay.
When I have somebody with eating disorders, we focus on intake of very, very high nutrient sources because we need good, healthy growth and development.
Such as, can you give us a couple of examples?
So instead of whole milk, we would go straight to skim milk because we want to minimize the high fat and high sugar.
Okay.
We would want fruits and vegetables, but no juice.
Okay.
We would want no frying of meats. I would want no soda, no Gatorade, nothing that's going to put more weight on her than the amount of benefit that baby is getting.
Great.
And I explain it to mom that we need enough weight gain. Her weight gain needs to be within the range that's recommended for her pre-pregnant BMI, but it can be at the lower end of that range as long as we're very careful that almost all of that weight comes from things that help the baby grow and develop, so the baby is safe. But that also means when baby leaves, the weight goes. On plotting the weight gain against the appropriate grid, I ask them if they want to see it. Sometimes they do, sometimes they don't. If they want food records, we do that if they feel safer. But the other issue is there's a whole other group that is really, really afraid of weight gain, and that's the ladies with a history of bariatric surgery. They've just spent all this time and money pulling down that weight, and the idea of gaining it again is terrifying. So we do the same thing for them. Very high nutrient, very low calorie choices. But in addition to them, it also has to be very concentrated sources of nutrients because space becomes the limiting factor for them. But the truth is, we're doing high nutrient, low fat, low sugar foods for everybody because no pregnant woman wants to keep a bunch of extra weight, and we don't want her to keep it either. So it's just more so with these higher risk folks.
Great answers. Let's move into our seventh question. Severe hyperemesis gravidarum is a serious complication that involves intractable vomiting with dehydration, electrolyte imbalance, ketonuria, weight loss, and possibly neurological disturbances and liver, even renal abnormalities. What's your experience with hyperemesis gravidarum? And what's your take on interviewing or intervening parenterally, and how much psychology plays a role here?
Historically, the inpatient folks have been afraid of aggressive nutrition support, including TPN, because of safety concerns and because of refeeding syndrome and things like that. Okay. But we know that it can be done. It can be done safely if there's good monitoring, and there are folks who specialize in that. As far as whether we need to treat hyperemesis, with more information that we have on the epigenetic effects of malnutrition preconceptually and during pregnancy, we know now that birth weight isn't a good enough outcome measure.
Okay.
And what that means is we have to treat hyperemesis sooner and more aggressively than we thought before to prevent both short-term and long-term problems with both mom and baby. As far as the psych part, it used to be thought, when I started working or before then, it used to be thought that the psych issues were what was causing the nausea and vomiting. This was somebody who just wanted attention, or this was somebody who really didn't want to be pregnant. And I suppose there may be some people for whom that is true. But the more recent research and the more practice that people have with this population, it appears to be the opposite, that it's the malnutrition and the dehydration that are causing the psych issues, including hallucinations.
Lovely. Let's move into our eighth question. Post-COVID, we are seeing a surge in the GI disorders among our patients. Pregnant women with pre-existing diseases of gallbladder or pancreas or stomach or intestine can benefit from nutrition services to promote optimal and maternal and fetal outcomes. What is your experience clinically with this?
It's interesting that you brought up long-term GI symptoms with COVID because we haven't noticed that here. Okay. As far as the COVID connection, I would watch the long COVID research to see if they find any interventions that can help break that cycle. But as far as the GI symptoms, we have lots of folks who are pregnant who have GI symptoms. We have nausea and vomiting. We have constipation, sometimes diarrhea. We've had gallstones. We have all sorts of GI things. And so we would deal with them individually just as if we would have anyway. COVID wouldn't add to that.
Brilliant. Jean, it was a great pleasure having you on our show today. We would like to thank you and hope to see you in our region very soon. Until then, thank you very much for being with us. And thank you, everybody, for watching our 8 Questions in 8 Minutes episode. See you next time.
Sounds good.